this was not because of her ACL tear. She was amazing on that hill. I think the line was just cut so tightly, she was capturing every single millisecond, and that hurt her. And then she hit the pole. That is what happens when you are a champion who pushes the barriers and the envelope of winning so closely. The margins are so thin that this time it broke her. I'm Doc Faisal, orthopedic surgeon with Move Smarter Health. We are sponsored by an educational grant from Kinesi Movement. I love sports. I love talking about injuries. I take care of shoulder and knee injuries, and I operate and treat on them. And please consider this an educational, informative video only. Here we go. Okay, so I know there's a lot of chatter out there, like, oh, it's because of her ACL, she shouldn't have done it. And someone even had the audacity to say that she took someone's place. Like, come on. Come on. No one else in the history of women's skiing, actually alpine skiing, has ever done what she's done with the injuries and made a comeback the way she has. ACL tear, left knee, and she's doing massive deep squats with a brace, getting ready for the Olympics. And she was blistering. I mean, there were turns that I'm like, oh my God. Like, I had to look away because she was going so fast. And it was a little icy. It was a little choppy. You could see, but she was tight. And then I think maybe she tried to correct. Maybe she tried to take the margin tight. But listen, these flags, these poles, yeah, they don't break off. They're not like, yeah, they're soft. But when you're going like 70, 80, 90 miles an hour, what was she going, 78?
Yeah.
Something like that. If you hit something, even if it's this plastic metal, or even this little metal bridge or this plastic tip, it's gonna hurt. You jump 20 feet into the ocean, it's gonna hurt. It's good sound effect. Thank you. Do you like how I compliment myself? Yeah. So, just caught her. Luckily she didn't break. That was the arm she broke before, right? Oh my God, when I saw that, I'm like, no! And then when she lands and crashes and I see the legs flailing, I said, oh no. Is that a bilateral tibia fracture? And I'm like, okay, no, I think it's just the left. And it was the left. And we don't know all the details. We know it's a left tibia fracture. We don't know exactly where it was. We don't know as much detail. Do we?
All we know is that she says it's going to be multiple surgeries.
Yeah. So we don't know all the details, but she did say that it's a complex left tibia fracture. Now, what does complex mean? Now, in the medical field, when we say complex, and it's old terminology, okay? Nowadays, we say closed versus open, and then there's classifications of open fractures. The old terminology, and probably what is more common in the public, is simple versus complex. There's different ways to interpret complex. The old school was if it's complex, that means it's not only in multiple pieces, but it's actually an open fracture where it's broken through the skin and something's exposed and you have to rush into surgery. However, that may be not how she's describing it, so I don't want to presuppose. I'm not her surgeon. I'm not her treating surgeon. I'm providing contextual education around injuries. And the tibia is your shin bone, okay? There are two bones in your calf. The tibia is the big one. The fibula is the smaller one. The fibula is on the outside. The tibia is on the inside. It's the big one that becomes a little smaller. Your platform, called the plafond, at the bottom of your ankle, is the tibia. The tibial plateau, which is the upper surface, which covers, I have a model. It's broken.
Of course.
Right? Nice. There's your tibia, right? There's your platform. This is your plateau. Where did she break it? We don't know exactly. She did have a plateau fracture on the opposite knee, which is the one that eventually got arthritis and she had a partial knee replacement. And that means it involved the upper surface. A proximal tibia fracture, extra-articular, means that it didn't involve the joint. No one said that it involves a joint in any of the news. She didn't say that. It wasn't stated that it's a plateau fracture. So as far as we're aware, it's a tibia fracture, okay? And that means that it's somewhere below the metaphysis, maybe in the shaft, more likely. And she didn't say it was the ankle involved. And this is the lower part of the tibia. The tibia goes down and you got the medial malleolus, you've got the plafond, which is a plateau upside down. You've got a plafond, you know, and then you have the fibula on that side. So as far as we know, it's somewhere in between in the tibia that it's broken, okay? Don't worry, Charles, I won't break you, okay? I know you want to see that. Wouldn't that be cool? Like just kind of like throw Charles down like a slalom course and see what happens? No, don't say anything. Okay, Joey's gonna cut that out anyway. No one likes this humor. I do. I think I'm funny. What do you think?
I have to leave it in.
Oh, the comments below will be amusing. So, definitely wishing Lindsey Vonn an amazing recovery. She's in good hands. She's going to get the best care in the world. I am sure of it. And wishing her the best for recovery. This was the same knee that she had the left ACL tear. She had the brace on. Now, one could argue, if you have a brace and you have an impact, will you break at the area between the brace and the leg? You could argue that all you want. It's equivalent to a motor vehicle crash. I mean, come on, guys. Don't blame her ACL. Don't blame the fact that she was in the Olympics with an injury. Then you might as well talk about all the other athletes that were playing with injuries. Like, at what point will a pro elite athlete decide not to go in? Ooh, I've got some tendonitis. Ooh, I've got like hamstring pain. I've got groin pain. Oh, I've got a pulled muscle. You're going to push through it. I mean, these people are working at the 99th percentile of stress in their body, maybe even 100%. Maybe you saw it, but the cross-country skier, Clable, Nordic skier, that's when they had old style of cross-country skiing and then the skate skiing, right? So they combine them, they switch their skis. Like, are you kidding me? And on the last hill, this is still mostly uphill, and he just guns it. Like, man, he just speeds up that hill, finishes first, several seconds ahead of any of the other the athletes. And then he's like, yeah, like he actually relaxed. Like right at the end, he kind of relaxed. He looked around and he goes, yeah, awesome. Whereas most of the other athletes that came in, they collapsed at the end. So these are monsters of the sport, right? They are pushing themselves to their limit. Maybe he pushed himself to the 95th percentile because it looked like he had plenty of energy left in the tank, plenty of gas in the tank, whereas the other guys behind him were probably at the 99th or 100th percentile. They put it all out there. They collapsed after they crossed the finish line. For the Nordic skier, not the Finnish skier. Ha, ha, ha. Is that a nice dad joke? That's a good dad joke. I like that. So anyway, so going back to Lindsey Vonn, she's a beast. And what does she say after this? No regrets. The power and positive energy of Lindsey Vonn is something we should all embrace because that is the super athlete of the century. My God, she should be in the Hall of Fame. They should create a whole new Hall of Fame called Athlete of the Century because I don't care that she didn't win that gold. I mean, I do. I wish she did. I was very hopeful. At least medal. Like, that would have been an incredible story, incredible comeback story. And maybe she'll come back next year. I don't know. But ACL and fracture, it's going to be a much longer recovery. Let's get into it briefly, but like, you know, athlete of the century, Lindsey Vonn, hope you heal well. Now, let's look at the situation where you have a tibia fracture with an ACL injury. Now what do? Well, you have to stabilize the bones first. If you don't have stable bones, then there's no point in doing the ACL. And are you going to do the ACL at the same time as the tibia fracture? Very unlikely. The reason is high speed, motor vehicle crash, if it's complex, multiple fragments, possibly open, that means the energy of that fracture is high. What does that mean? Come on, I know you know this. Yeah, that was a junior resident out there in Alabama that said the right answer. I hear you. So the answer is your risk of compartment syndrome, swelling, fracture blisters, all of those are high. Now, immediately she's going to be splinted, they're going to have ice, anti-inflammatories, get the swelling down. I know there's arguments about anti-inflammatories in fresh fractures. I hear you, it's controversial, I get it. Priority is getting the swelling down, unless she needs to go to surgery right away if it's open, right? So there's a lot of factors involved. Then do you rod it or do you plate it? And do you do a full trans suprapatellar rod, or do you do a traditional rod? Why is that important? Well, a traditional nail, you're going to entry spot is right about here. So you're actually making the entry and then you're putting it central in the tibia, but it's actually in front of the ACL. It's probably about a couple of centimeters in front, slightly inferior to the ACL, and behind the patellar tendon. You want to stay extracapsular when you do this. And that's the goal. So you're having a rod put in. Now, what if you do plates? What if it's a complex fracture, metaphyseal, you have to use plates? Okay. But ideally, typically these days, especially in trauma, if you can do an intramedullary nailing, a rod, then you'll do the rod, okay? Now, what if you have other situations? I hear you from Connecticut. Yes, fat embolism syndrome. If you nail something too hard, too fast, and ream it, and you have multiple fractures, you're gonna create fat that goes into the lungs, and you'll go stop breathing and have pulmonary embolism, fat embolism syndrome. Absolutely, that's a risk. Okay, isolated fracture, single bone, the risk of that is low, but it is high energy, and she's had multiple injuries. Is she at risk for a blood clot? Absolutely. Is she at risk for fat embolism? There's always that risk. Now, these days, you might do, low energy reaming, limited reaming, or unreamed nail, so you avoid that risk in a trauma situation. And there's data all over the map about it, and that's why there's fracture trauma experts. And the data, you have to go by the evidence. And so I'm sure she's in good hands. All of that data is known by top trauma experts in the world. So what are you going to do? Stabilize the bone. Because if you don't have a stable foundation, like concrete platform to build a house on, there's no point in putting windows and curtains, right? Now, I'm not saying the ACL is a window or curtain, but my goodness, if Lindsey Vonn can ski in the Olympics without an ACL, then why do we need ACLs? I'm kidding. So.
It's a real question that came up on Twitter, though.
Oh, really?
Are ACLs cap?
Yeah, no, ACLs are important to overall rotational kinematic function of the knee. And even with an ACL brace, you are not fully protected from an ACL tear. I think with Lindsey Vonn and her muscle, neuromuscular kinematics, and her overall craniocervical neuromuscular connection to actually know her body so well, and she's so in tune with the mechanics that she can build it up and be strong in a brace, and with her movements, maybe get away with it. Now, it's still a high risk. I don't think, whether she had an ACL tear or not, in this situation where she was cutting the margin so close, she more than likely would have still had an injury if she hit that pole. Whether or not she had an ACL or not would not have made a difference, because where did the problem happen? It was when she flew around the turn, smashed that, and you saw her, all of a sudden she's going like this, right? So her entire aerodynamics are off, her body mechanics are in a rotational torsion position, and so her entire line is gone. Her momentum and torque is opposite to where she needs to go, and so her landing was off the mark. So do you need an ACL? Yeah. If you're a computer engineer that sits at a computer all day and doesn't do any competitive sports, no, you don't need an ACL. You might just get a little bit of laxity, but then in the end, you're not pushing your body beyond the 40th or 50th percentile of mobility and function and agility and endurance and strength. So if you're not doing that, you're not pushing your stability, then you're just going to get a stiff knee. And if you have a stiff knee, but you can still do your job, you're not going to care. So we need to frame the question of whether or not, why do you need ACLs? There are different tiers of need. PCL is a great example. If I were to blow out my PCL, I could probably get away with not getting it reconstructed. If I blew out my ACL and PCL, absolutely no. I would get it fixed. I still play tennis. I like to run when my knee doesn't hurt. And, you know, just swimming. I've actually, you know, okay, go ahead and make fun of me. You do a flip turn fast enough, it hurts if you twist that knee, okay? So there's all sorts of different sports that you can play that can affect that. If you're a soccer player, you need your ACL, okay? Why do you think they all get their ACLs reconstructed, right? So, and just because the surgery outcomes are variable, imprecise, inconsistent, and not everyone is happy with it. You get proprioceptive issues, you get this, you get that. There's so many different ways to do an ACL reconstruction, okay? But for the most part, just because the data is variable doesn't mean that there's a problem with whether or not you have the ligament. Maybe we just don't understand the ACL well enough. And that is a great question. We're addressing that with kinesi, that's for another day. But understanding the ACL kinematics, in vivo, live, real world, real life events, when you are actually doing what you love to do, whether it's life, playing, sports, or work, that's the understanding you get. And that's what you need to have. Not how it works in a lab, not how it works in a simulated proxy of a clinic or a test lab or an artificial simulation or anything, or watching it remotely with video cameras and body markers. No, you want to see inside the knee. You want to see exactly what you want to be as close to the joint kinematics and movement as possible in real world kinematics. We don't have that yet. We do, but you don't. But it's coming. So anyway, little segue. Question.
Why she emphasized the multiple surgeries to come back from this? Why?
So that's a really good question. So that goes back to her comment about it being a complex tibia fracture. So was it open? And if it is, then it was open enough. Did she have a nerve injury? Did she have a vessel injury? Did she require an external fixator to stabilize it and allow the soft tissue envelope to heal before you can actually do the final fixation? Does it require a repeat debridement? Now, for the most part, she's covered up in this second skin ski suit, right? But if it breaks the skin and tears the fabric and you rip it open, it's exposed to the elements. I mean, you're talking about skiers that have run over this track multiple times. There's dirt, there's grass, there's snow, there's probably all sorts of stuff, right? And so that can get in the wound. So there's the risk. Is it a dirty wound, right? So if it's a dirty wound, you have to wash it out. And if you wash it out and it's a tiny puncture hole, you can probably get away with fixing it right away, unless it's high energy. And hers was a high energy injury. Did she have degloving? Okay, degloving, yeah. Yeah, even Joey got scared of that. I don't know if he knows what it is, but that hurts. So degloving, like just the term, imagine you're ripping your skin off. That's not necessarily what degloving means in an injury, but in an injury, the skin could be intact, but what happens is that sorry, let me use this. Ooh. The tissue plane, the fascia planes, relative to the bone or even the muscle, there's a laminar trauma due to the force vectors, due to the injury where the tissue shifts and the bone or tissue to tissue or bone to tissue has a disruption. So you can get fascial, fat, muscle, tissue, injury aside from the bone, and that can create basically a pocket of fluid because the fat can liquefy, the blood collects, compartment syndrome. The fascia, if it's not contained, and even if it's partially torn, you can still get a compartment syndrome in an open fracture. Yes, that Stanford resident was right because I trained him well. Okay, so that can happen with degloving injuries. And so if you have a major soft tissue envelope disruption, your risk of infection is higher. If you have a vessel injury, a nerve injury, or we don't know, but if say there's also cartilage damage, say it was a plateau and there's cartilage damage, but it's an open fracture, you have to try and restore the cartilage, but what if the cartilage is completely smashed and disintegrated? If that's the case, and it's an open fracture, unless you can stabilize it and it's a large enough piece, you may not have a choice but to get rid of it. If it's little bone dust and cartilage dust, that means that she could have defects. That might require further surgery. If there's bone missing, that requires bone transport or multiple surgeries. But even sometimes a simple fracture, which may be open, meaning it's a clean break, but it's open, you may have to just stabilize it. Most of the times we do put it in an X-fix, but you can still treat it in a cast with a window and make sure you monitor the soft tissue envelope and check for compartment syndromes. It requires more diligent, regular care if you have some kind of a splint and not a full cast, but you can do that if you have no other choice. And certainly there's lots of good fracture care in developing countries where they don't have access to the kind of materials and supplies and instruments and technology that we have. So we're lucky, right? So you could put an external fixator on, and you put the fixator on, and then later, after 2, 3, 4, 5 days, sometimes 2 weeks, you come back and put the rod in. And the other situation is, maybe she's just talking about, first she has the tibia fracture, and then she gets the ACL. So that's the other factor. Now, this is going to be an interesting, question. How long do you wait? Like, say you get the tibia fracture fixed. How long do you wait until you do the ACL? Well, that's a really good question. If it's an open fracture and you do the tibia, high energy or not, there's a risk of infection with another surgery. So now you're going into the joint with ACL reconstruction. So are you then introducing risk into the joint with the ACL reconstruction, depending on the graft that you use? For her, more than likely quadriceps autograft, or maybe not bone, tendon, bone. You could do hamstring, but you're going into the joint regardless. Even if you do it all inside, mini open, partially open, arthroscopic assisted, however you do the reconstruction, variabilities, and we've had a whole video on that. Then the question is, are you putting that at risk when you have a risk of infection from the tibia fracture? So this is open up like a whole can of worms about that. And so that really brings down the clinician expertise, the clinical guidance, and the evidence. What do you do? Now, how many people at her level of elite Olympic athletic prowess have had multiple injuries with a recent ACL and a complex tibia fracture? Again, we don't know the details about how many fragments, Is she calling it complex? How is the soft tissue envelope? Is that why she's calling it complex? Or is there an open fracture, meaning a wound is just disrupted to the air? So we don't know all that detail. But that combination of injuries, you're not going to find a study of 1,000 patients to sort of say, oh yeah, I know the answer. We have done a study with reasonable arm and MID and power to detect a difference, and we actually had enough power to do an equivalent study or non-equivalent study. Absolutely impossible. I can guarantee you that no one has 1,000 patient trial in her specific individualized data information where you have that quantified human self to actually understand what the best treatment for this athlete is. But we have generalized data, and you can make inferences and understanding and assimilate all that information and come up with the best practice guideline for that individualized patient care. And you have that conversation. So this is where Lindsey Vonn more than likely has a detailed, lengthy conversation with her family and her surgeon, says, okay, give it to me straight. What's going on? And I'm sure she's done that before. She's doing that, and I'm wishing her well. We'll keep you updated about her progress.
Hey, you mentioned something about it being controversial for anti-inflammatories with a certain type of injury.
Yeah. So a question that was from the peanut gallery back there is a good question. What is the issue with anti-inflammatories in fracture care? Well, there is some data that suggests that anti-inflammatories, ibuprofen in particular, can reduce the inflammation. However, the inflammation and the inflammatory markers and the actual constituents of inflammation that want to actually promote healing are then disrupted. That chain of inflammation from inflammation, swelling, splint, control to hematoma, and eventually remove that by the body's natural healing process can actually be affected and reduce fracture healing, because there's data on bisphosphonates and anti-inflammatory to say that it can affect bone healing. So that is the controversy. So do you use anti-inflammatories in a fresh fracture? I have recommended it in certain select cases short-term to alleviate the short-term inflammatory effect if I'm worried about something and the patient's not going to surgery right away. Yes. Do I recommend it long-term for patients during a fracture healing? No. Do I recommend it in patients who have osteoporosis and a fracture? I don't. But there's data camps on both sides, and that's the controversy. Anti-inflammatories and bone healing. And it's the biology. It comes down to the biology. We should just put a whiteboard up there and I can go down into it and bore you out of your mind if you wanted. But yeah, I know. I hear you, Florida. Yeah, you want to hear about it, but we don't have time today. See you next time.